Hi everyone, this is Dr. Sandeep Sharma here. Life is complicated and so is medical science. But whether you are an MBBS student or targeting competitive entrance exam or a resident in medicine or pediatrics, there are a few concepts, if you simplify them, they will always come handy to you. So through this series of mine, I'll be trying to simplify some of the important concepts in common things that you often read, that you often encounter, but fail to fathom the underlying pathophysiology behind them. And in this part 1 video, I have talked about Cushing's Triad. So let's try to demystify Cushing's Triad.
Now, this is the photograph of respected pioneer American neurosurgeon Dr. Harvey Williams Cushing. He not only described Cushing's disease, which is Cushing syndrome caused by a pituitary adenoma, but he also described what we now call as Cushing's reflex. He was the first to elaborate the neurophysiological response to acute elevation in ICP in 1901. He proposed what we now call as Cushing's reflex, and Cushing's reflex was later described to constitute a part of Cushing's triad, which is seen in raised ICP. So what exactly is Cushing's triad? See, whenever there is an acute and significant rise in intracranial pressure, three things tend to develop. One is hypertension. It is mainly a systolic hypertension leading to a wide pulse pressure. The second component is bradycardia, and the third component is irregular respiration. Some of the texts, some of the authors call the third component as bradypnea, that is slowing of breathing rate. However, irregular respiration is the more appropriate term. This was the original Cushing's triad as mentioned in most of the texts. So, what exactly is happening? Now you know that brain is a metabolically active organ. Brain tissue requires a constant perfusion to ensure adequate delivery of substrates like glucose and oxygen to the neurons as well as to astrocytes. And for that, an adequate cerebral blood flow is of paramount importance. Now, cerebral perfusion pressure is the major determinant of cerebral blood flow. So how is it calculated? There is a formula for that. Cerebral perfusion pressure is dependent upon the mean arterial pressure, and if you subtract the intracranial pressure from it, we get the cerebral perfusion pressure. So CPP depends majorly upon the mean arterial pressure because ICP is usually on the lower side. Now, normally cerebral blood flow shows autoregulation for MAP ranging from 60 to 140 millimeters of mercury. What it means is that MAP means your mean arterial pressure. It can be decreased acutely to as low as 60 millimeters of mercury or as high as 140 millimeters of mercury without significant change in the cerebral blood flow. But whenever there will be a rise in intracranial pressure, this will create problems in the cerebral perfusion pressure. How? Have a look. Whenever ICP rises significantly, go back to the equation. What was the formula? CPP was MAP minus ICP. So whenever ICP will rise significantly, the cerebral perfusion pressure will fall. Simple mathematics, right? So the compensatory mechanisms will get activated to maintain CPP. Otherwise, the brain will undergo ischemia, it will undergo hypoperfusion. So what happens? This is what the pathophysiology happens. So you have in raised ICP, to maintain the cerebral perfusion, initially there is sympathetic activation. So sympathetic activation or sympathetic stimulation will lead to rise in the blood pressure levels, mainly the systolic BP. Because systolic BP rises and diastolic BP is usually slightly on the lower side or tends to fall, there is a wide pulse pressure which is seen in these patients. And initially there may be a slight elevation in the heart rate as well, what you call as tachycardia. But this tachycardia is usually not considered to be a feature of the Cushing's triad because most of these patients, the tachycardia which you find is gradually replaced by bradycardia. So as raised ICP persists, you will find that the hypertension persists, but instead of tachycardia, what develops is bradycardia, right? Now, why bradycardia develops? There are two theories for that. The more commonly, the older theory, it says that hypertension leads to activation of baroreceptors in the aortic arch, which causes parasympathetic activation, right? And parasympathetic activation will lead to cholinergic response at M2 muscarinic receptors of the heart, which will lead to bradycardia. The second theory which is mentioned in some of the journals, which is also favored these days by many of the physicians, is that there is compression of the intracranial vagal nerve, which leads to bradycardia. Now, you need to remember that parasympathetic activation which is happening, it does happen to a certain extent, even though it may not be prominent in a subset of individuals. But parasympathetic activation will also lead to stimulation of parietal cells in the GI and lead to ulcer formation, what we call as Cushing ulcers. So this is the reason why Cushing ulcers tend to develop in raised ICP. Continuing with the discussion, because raised ICP is still persisting, and if nothing is done and ICP rises even further, what you find is that there is hypertension, there is bradycardia, and now irregular respiration also comes into play because of the development of brainstem dysfunction. In the some of the older texts, you will find that they define Cushing's triad in three parts. Initially, there is a hypertension. The second stage, you will find bradycardia, and third stage, you will find irregular respiration. Irregular respiration will progress to bradypnea, or complete respiratory arrest can also develop. So, what is Cushing reflex? Presence of hypertension with bradycardia is called as Cushing reflex. If all the three are present, hypertension with wide pulse pressure, bradycardia and irregular respiration, we call it as Cushing's Triad. And this is the pathophysiology that you are supposed to remember. The older theory as well as the newer theory, extremely important for your exams and for your vivas and for your general understanding of the disease. However, you need to remember that Cushing's triad is unfortunately a late sign of increasing ICP, and always keep a high degree of suspicion to watch for subtle signs of raised ICP like headache, vomiting, altered sensorium, which tend to appear early.
So I hope you benefited from this discussion. In case you want me to take up some other interesting topic and want me to simplify it a bit, I'll be more than willing to take it up. See you with the part 2 of this series very soon. Thank you.